So I'm just going to talk about presbyopia surgery. So I'm just going to give you an introduction on what the options are and some of the general results, and then you're going to have some more detailed speakers after this. So we know presbyopia affects a lot of people. Some studies say more than a billion people, but it's probably more than that. And obviously, in the third world, it's a much bigger problem, because if you can't see for near vision because you can't afford glasses, you can't work sometimes. So when it comes to surgery, we have a little bit of a problem in that there are two theories which tell you about how and why presbyopia occurs. So we have the Helmholtz theory and the Shah's theory, and there's a difference in what their mechanisms, and yet there are surgery designed based purely on one of the particular theories as to why they should work. So we know what the problem is. For surgery, why do people come to have surgery? They don't want to wear their glasses. I mean, it's quite simple. If you're a contact lens fitter, you're very familiar with fitting monovision, but monovision doesn't work for everybody. We know that. Obviously, in this case, this is a little bit extreme, but it works in a portion of people. And there are more than one distance that you have to cover. So it's not just distance, it's not just reading. People want to be able to do everything in their life without wearing glasses if they can. So when you're looking at somebody for surgery, you need to actually consider three separate areas. One is obviously the far distance. Then you have the reading, but there's intermediate, and you'll see. So intermediate, we include computing, and I've put your phone in both in the reading and in the intermediate, because different people want different things out of their phone. Some people are quite happy just to be able to make out text, but other people obviously want to use the phone for their work as well. So I'm going to talk about the extraocular surgical options, and then we're going to talk about the intraocular ones. So when it comes to cornea, we're all familiar with excimer laser. So there are different options that you can use with an excimer laser to give near vision. There are the thermal techniques, which are not used so much anymore. There's a femtosecond intracorneal rings and corneal inlays. And then on the scleral side, we have scleral expansion bands, and a couple of different lasers, and I'm just going to run through these different options. So with the excimer laser, what can we do? I mean, there are multiple approaches to giving you near vision. Obviously, you're trying not to compromise the distance vision, and this is where the problem arises. So you can do traditional monovision. This is very easy. You can try it out with a contact lens before you try the monovision. Or you can do a multifocal approach where, and there are two main ones which are being used at the moment. There have been many companies who've tried this, and there's a variety of bifocal corneas, aspheric corneas, actual rings on the cornea itself, but most people have come down to changing the asphericity of the cornea, and these are the two main companies who are pioneering this at the moment. So thermal keratoplasty has a long history. I mean, it was first described in 1898. The fact that people are still trying it usually tells you something about the technique, that it doesn't work. So people just try different mechanisms to achieve this. So you're essentially creating a change in shape by thermal burns in the cornea. And as you can see here, there's a change in the histology on the cornea, and we're looking for shrinkage of the cornea, which will then change the shape. So these are some old pictures. So you can see you've got some changes, effectively scarring in the mid periphery of the cornea, and some central changes. The difficulty with something like this is keeping the cornea regular, because you can't get a thermal burn effectively, which is completely regular. Then a lot of people ended up with irregular astigmatism, dropping both their distance and their near vision. So one of the companies is Bausch & Lomb are pioneering intrastromal femtosecond concentric rings. This is called intracore, and the idea is that you don't open these up at all. It's just done intrastromally, and you get a slight steepening of 1 to 2 diopters in the central area. And you can see on these pictures that straight after having the femtosecond, you can see the air bubbles within the cornea itself. And within a day or a week, the air bubbles have gone, and you can't see very much anymore. And the aim is to increase the asphericity. So what's something which is very popular, certainly in the refractive press now, are corneal inlays. So here we're trying to put in a device within the cornea to change the near vision. So there are a number of different ways of doing this, and the first one of this was the camera inlay. So this has you're trying to create a pinhole. That's all it is. And typically you put this into one eye. The device has a 1.6 millimeter aperture, and it's 3.8 millimeters in total. So you can see the device there, and on the cornea itself there. So it's quite a small device. You put it in, it's only 5 microns, which should be thick, not think. But you put it into a pocket created by a femtosecond laser, which is 200 microns deep. Quite a few of these have gone in. There's one clinic, particularly in Japan, which was putting in thousands of these. But a number of people have found problems with centration and a late hyperopic shift. So in theory, these are reversible. Because you can just open up the pocket and pull them out, but there's probably some scarring left behind after this, and some changes. So there are other types of inlays. One of these is called the Presbyer Flex View. So this is a device which is 3.2 millimeters wide. So all of these are quite small, and they're quite tricky to handle. I mean, this one's also 15 microns thick. But this one comes in a variety of powers. So depending on the age of the patient, you can put in either a 1.5 ad or a 3.5 ad, or something in between. So you have to think about this a little bit as to where you want to leave them, and whether you're prepared to do further surgery for these patients in the future. The central area has no refractive power, so you're not going to affect the distance. And once again, you need to do a femtosecond pocket, and as you can see there, it's within the pocket. You have you just have the device, 15 micron thick device. So another one is called the revision raindrop. So you can see the actual size, and so you have to get this into the corneal pocket without wrinkling it, and right in the center. So little bit of practice, and again this is a needle, and you can just about see the device there, and you're just trying to change the asphericity of the cornea. It doesn't have any actual refractive power. This device is actually a little bit thicker than the others at 32 microns. So what about surgery on the sclera? I mean, one of the things you should take away from this talk is when there are so many different techniques to tackle the same problem, none of them work properly. So you have to choose from your patient, and you have to choose what compromise you're prepared to make. So one of the older devices which isn't really used anymore is a holmium laser to create radial scleral incisions. And literally that's all you do. But a newer technique which is sort of being developed is called the laser race. And with this laser, you're just making little spots going down to 90% thickness of the cornea, of the sclera, sorry. And the latest results on those, they give you an average of 1.5 diopters increase in objective accommodation. The problem with all of these sort of studies is comparing objective to subjective refractions, because the subjective often is better than the objective. And they have 95% of patients have intermediate vision of 0.18 logmar. So on the same sort of technique, we're talking about sclera expansion bands. So all of these are based on Shah's theory. And the idea is that by expanding the sclera in certain positions, you allow the ciliary muscle to work as it would normally. So this is one of the such devices, and the idea is that you're putting a plastic implant into the sclera in 4 different quadrants. So the beauty of this is it's outside the line of the visual axis. They're removable, but it is horrible surgery. You actually have to open the conjunctiva through 360 degrees. This is under topical anesthesia. It takes about an hour to do. And the eye remains very red for 3 to 4 weeks, and they often have dry eye, which doesn't resolve. So we've just finished a study on the latest version, and they're just in the process of getting FDA approval. So these will be around, but even then, the improvement is modest. So 2.3 lines of improvement in near vision, and you have this wasn't compared to a control group, because if you do something to somebody, they'll often read better just because they want to read better. So you can't be sure that this is a real improvement. But 100% of the patients got 0.3 logmar with the best distance corrected near vision. What about intraocular surgery? So there's 2 types of intraocular surgery you could do. One is on a phakic eye, and one is making an eye pseudophakic. So multifocal phakic intraocular lenses have been around for a little while, but they were withdrawn because there were problems with the corneal endothelium. I'll show you some pictures in a minute. But Artisan are just about to bring out their multifocal phakic IOL, and the ICL multifocal phakic lens is also in trials. But pseudophakic, this is one of the biggest growing refractive surgery markets at the moment. I mean, my practice now has gone from largely laser to I do probably 80% clear lens extractions. So this is to do with the type of IOLs we have available now. So obviously you can do monovision. In a patient who's had successful monovision in contact lenses, there's absolutely no reason to change that. You can go multifocal lenses, you can go accommodating, and the new group is the extended depth of focus lenses. So you'll be hearing quite a lot about this new group over the next few years. So if you've got a presbyopic IOL, what is it that you want? You obviously want excellent distance vision. You can't compromise that. You don't want to lose contrast sensitivity. I mean, you'll be familiar to this from contact lenses as well. It's a lot of the designs of our intraocular lenses have come through multifocal contact lens designs first. So you also want excellent near vision, excellent intermediate vision, because you want everything. You don't want any halos and glare. You don't want it to be dependent on the pupil. And you can't have it not working when it's dark. Of course, all of that is impossible. But you need to have easy surgery. I mean, you can't be doing a cosmetic refractive procedure on somebody and have a complication. From the surgeon's point of view, the only important one is the last one. What you don't want is a patient who's unhappy. So you want to be able to put in a lens and they are happy. So you have to find a lens which will give you as good a result with all of those as you can. There isn't a lens which will give you everything every time, but you have to try and fit the lens to the patient. So we just, on the phakic lenses, this is one of the monofocal ones and the same design in a multifocal one. So here you have the possibility of correcting their ametropia as well. It's very straightforward to do. It's an anterior chamber lens. In theory, it's reversible, but has all the same problems of multifocal in the bag lenses. But on top of that, it's right by the cornea and it's sitting in the angle. So you have to be careful about glaucoma and endothelial cell loss. So these patients needed endothelial cell counts for the rest of their life, and all the designs which have been made have had problems with endothelial cell loss after a while. So people don't tend to put these in anymore. So as I said, the artisan lens is coming with a multifocal design. The difficulty there is going to be centration, because you have to center perfectly, and so we'll wait and see what the results of that are. And also the ICL is bringing theirs out shortly. So if you're putting a lens in the bag, so if you're going for a clear lens extraction, relax, whatever you want to call it, you have to remember that different lenses do different things. So there are some lenses, particularly the soft aberration-free ones, which will actually give you a degree of pseudo-accommodation. So one of the ones I use gives you typically 0.75 diopters of pseudo-accommodation in a monofocal lens. So that may be adequate for the patient, but you can do monovision. There are lots of choices for multifocal lenses, so you have to decide what you want and what design you want. And there are accommodating lenses, and of course you can do mini monovision with that, because we know accommodating lenses don't give you a full range of accommodation, so you can supplement that with mini monovision. And the extended depth of vision lenses are also similar in that they give you intermediate, but to get a full range, you'd have to do mini monovision. So when we say mini monovision, we're talking about leaving one of your eyes about minus 0.75 diopters. So people have bad feelings often about multifocal lenses. And one of the reasons is the old designs of lenses. So this is one of the original ones. And certainly in my hands, I used to have to take out 1 in 10 of these because people couldn't tolerate the side effects. So it was so bad that I actually stopped putting in multifocal lenses for a while. But now everything has changed. So if you have it in your head that multifocal lenses are bad, that's no longer true. So one of the things that people feel is you have a decreased contrast sensitivity, but most of the new lenses, they give you the same level of contrast sensitivity as you would if in a normal patient. You don't lose any contrast sensitivity at all. Similarly for night driving performance, unimpaired, so the FDA now is expecting a night driving simulator if you're having multifocal lenses, so you have to be able to pass that test. And previously you'd have a compromise, and now we don't really expect any compromise. But with all multifocal lenses, you have to have accurate biometry. If you're off target, it's just not going to work. So there's an interesting study presented last year looking at why do people get problems with multifocal lenses and which lenses are more susceptible to this. So if you look at this, the results of this study, if you look at the optical principle of the lens, the lens design which gave you less halos and glare was a refractive lens. And the higher halos and glare was with a diffractive lens. As you'd expect with the additions, the size of the addition, the higher the addition, the more halos and glare you get. So the lenses which were produced initially were quite high-ad lenses, and the tendency now has been to drop the addition down further and further. So one of the reasons is to reduce the halos and glare. And of course, if your target refraction is 0, you need to get on target with your biometry. If you're not on target, you will increase your halos and glare. And if you look at some of the designs of lenses, this is the design I tend to use at the moment, which is called Oculentis M+. And in this particular study, it came out that this lens produced the least halos and glare. After that, the extended depth of focus lens, the Symphony, which is a diffractive lens, had slightly more halos and glare, but the trifocal in this study had quite a lot. So if you're putting in a multifocal lens, the best lens for dysphotopsia is refractive with a low ad. You need to be spot on target. Has to be well centered. A lens which is decentered causes problems, and you have to treat the astigmatism. You can use accommodating lenses. There was a phase when these were very much in vogue, but they've gone pretty much out of favor, except for certain circumstances. You'll still hear about these a lot because in America they're about 6 or 7 years behind Europe on intraocular lens design, so they use what they're able to use. So they still talk about the benefits of the crystal lens, whereas nobody I know in Europe started to use the crystal lens in great volume. But one of the original ones was the 1CU. This is the Lenstech Tetraflex. This is the crystal lens, and this is a dual optic one called Symphony. Everyone's gone quiet on this one as well, so there's very few people around using these in any volume. So this is an interesting slide. I'll go through it in a bit more detail because there's a lot of information on here. So one of the ways to measure how well a lens works is by what's called a defocus curve. So what you do is you present a target to each patient at different distances or different levels of defocus to see how clearly they can see at that that level. So what you're trying to do is simulate for each level of defocus or distance. So obviously if you're -1 defocus, that's a 1 meter. If you're minus 2 defocus, that's 0.5 meters, and minus 3, 33 centimeters. And that goes with those pictures. So you're trying to see what somebody can read with that particular lens at that particular distance. So it's the only way of getting an objective global picture of what a lens can do. So the first chart is a monofocal lens. So what this is showing you, as you'd expect, you get very good distance vision, and then it drops off rapidly. So you're only getting that only covers just over 40% of your visual requirements. So if we put in monofocal lenses, both eyes at emetropia, we're only covering just over 40% of their people's visual requirements. That might be fine, but they need to be aware of that. So then there's a choice of different lenses, and what you're trying to do is get 100% coverage of the vision. We're not really going to do that, but it's by creating a profile for each lens, you can tell patients what they can and can't see at different distances. So by combining different types of lenses, you can get very close to almost perfect vision. So the first one here is a comfort, which is a plus 1.5 lens in one eye, in the dominant eye, and a plus 3 lens in the non-dominant eye. And you can see straight away you've taken a coverage over 90%. And then you can, if you just put a 1.5 lens in both eyes, you will expect to see distance, you'll expect to see intermediate, and you'll expect some near. And that's what that second graph is showing. And you can, so these patients will have good distance and good intermediate. They actually have better intermediate than somebody who's got a higher ad in the other eye, but they won't read as well. So, but these patients get very little dysphotopsias. A 1.5 ad lens gives you next to no dysphotopsias. So for some patients, particularly a patient who's very particular about their vision, I mean, I have a ENT surgeon I have to do shortly, and you know he's going to be unhappy with the quality of vision because he operates down a microscope all the time, and I will not put in a high ad multifocal for him. If anything, we'll either put in a monofocal or we'll put in a low ad one. And if you look, so these are the combinations of lenses that you can do. The Panoptics is the Alcon lens, and actually in this study didn't perform very well at all. There's the Lisa trifocal. The Symphony, which is the extended depth of focus lens, that performs quite well, but when you're doing when you're giving mini monovision, because it behaves very much like a low ad otherwise. So the holy grail for refractive surgeons is presbyopic surgery, and as you can see, we're still continuing, we're still trying to achieve perfection, but unfortunately we're not quite there yet. Thank you.
Thank you, Sunil. Just stay here, a few questions. Qualche domanda per il professor Shah? Then I will start with one. Can you give us any suggestion about the indication according to age, your indication according to age? Patients lower than 50, older than 50, older than 60? What's your habit? Ho chiesto qual è il suo approccio a seconda dell'età dei pazienti.
I think now with the lenses that we have available, I'm happy to do a refractive lens exchange on anybody who's presbyopic. So I'm not differentiating on age. I'm just differentiating on what their visual requirements are.
So you are not using corneal approaches at the moment?
No.
Mi pare sia chiaro.
What's your opinion about toric multifocal IOLs?
They work very well. The problem is always getting the right measurement, the right calculation as to which lens you need, and aligning the lens. But if everything's correct, they work very well. I think you just have to have a higher expectation to do some laser afterwards, just to correct.
Domande dall'uditorio? Well, thank you, Sunil, for being with us today. Thank you, and have a safe trip back to
Thank you.
UK. Bye.